52-year-old male came with a history of abdominal pain, hematuria, abdominal distension. On CCT of this patient, we got approximately 6 into 7 into 10 centimeter of hypodense, ill-defined, irregular border, heterogeneously hypodense. HU of this lesion is 36. Seen in the right lobe of the liver. Post contrast, this lesion appears hypodense on the arterial and the portal phase. This is the venous phase, and shows the filling in a delayed phase. So on, we look after the filling phase. This is the delay phase of the same patient. Here we can appreciate that on the delay phase there is a filling of the that lesion which were appreciated hypodense on the arterial portal and the venous phase. On venous phase, we can appreciate that there is a multiple stellate lesions surrounding this large hypodense lesion, uh, an evidence of approx 2.4 into 2.1 centimeter. On arterial phase, we can appreciate that there is evidence of approx 2.4 into 2.1 centimeter of round oval hyperdense, 84 HO on the non-contrast and 130 HO on the arterial phase, present on the segment 6 of the right lobe of the liver. And this lesion is not showing enhancement on venous phase. So this is a physical history of a metastasis. Also, there is evidence of 6 into 5.8 into 7.6 centimeter of size ill-defined, large, heterogeneously hypodense solid type nodal mass lesion noted at the site of the periampullary. This is the periampullary area, causing the compression over the second part of the duodenum and the luminal narrowing. So this is causing the luminal narrowing. Here we can appreciate that this nodal lesion causing the narrowing of the second part of the duodenum. On post contrast, this lesion showing the heterogeneously enhancement with the multiple non-enhancing hypodense area within it suggestive of necrosis. So non-enhancing area within it is suggestive of the necrosis. This mass lesion is encasing the distal end of the common bile duct. So distal end of the common bile. This is the common bile duct, and it encasing the distal part of the common bile duct and the proximal pancreatic duct, and indistinguishably from the head of the pancreas and second part of the duodenum, and compression over the cystic duct. So here we can appreciate this is causing a compression over the cystic duct. The gallbladder is full of the distended, but this is a full of sludge material. Common bile duct is appears to be dilated at distal end, measuring approximately 8.3 centimeter. Here we can see 8.3 centimeter. Also, there is evidence of retraction of the liver capsule. Liver capsule retraction mainly in the two cancers. First is the cholangiocarcinoma and second is SCC. Common bile duct is appears to be dilated at the distal end, appearing approximately 8.3 mm. So common bile duct is measuring about 8.3 mm. Common hepatic duct diameter is 1.2 centimeter. Right and left hepatic duct as well as intrahepatic biliary radicals are dilated. So here we can appreciate that common hepatic duct, right and left hepatic duct as well as intrahepatic biliary radicals are dilated. There is also evidence of 1.3 into 1.1 centimeter of size heterogeneously enhancing filling defect seen at the bifurcation of main portal vein. So this is the filling defect in the bifurcation of main portal vein, which is extending into the right branch, suggestive of the tumoral thrombosis. A right branch of the portal vein is not opacified. Also here we can appreciate that there is 1.4 into 1.6 centimeter of size hypodense filling defect seen in the inferior vena cava. This is the filling defect in the inferior vena cava, suggestive of thrombus formation. Multiple enlarged post-contrast enhancing lymph nodes with non-enhancing areas within it, which is suggestive of the necrosis, noted in the peripancreatic along laser curvature of the stomach and a pre and para-aortic region. Here we can see the pre and para-aortic region with largest measuring 2.6 into 1.8 centimeter along the laser. So this is the largest measuring lymph node with the central necrotic area which is present around the laser curvature. Spleen is also enlarged in size 15.8 centimeter, and there is evidence of the gross ascites over here. On visualized lung part, we can see that mild pleural effusion noted on the right side. We advise the patient for histopathology correlation and advise that is a neoplastic etiology. So it could be because of the SCC or the cholangiocarcinoma. But as per the morphology and pathological presentation of this patient, this is favoring towards the cholangiocarcinoma. The retraction of the liver capsule is there. There's a non-dilatation of the main pancreatic duct is also there.